Assalamu alaikum ji. I'm really grateful to the organizers for having this very important session on patient safety. Something which is very close to the heart of everyone who is concerned with medicine, deals with medicine, either in the form of a professional doctor, a medical professionalist, or regulatory bodies like DRAP, or those who are in the process of making medicines like from the pharmaceutical country. So a very important factor which involves all of us equally. So patient safety is one thing that we feel, and I personally feel, is not given that much significance and importance in our country as it has been given to anywhere else in the world. So at times, I myself being a practicing surgeon, I know when I was working at the JPMC General Hospital, or later on I'm working in the private sector now, that patient safety does not come as one thing that we should be taking care of as the first step. And that is what we want our new generation of doctors who are coming up, that they should be aware of that. So a panel which represents almost everyone from physician, Aftab Sahab, from surgeon, to those who are in regulatory bodies, from Pharma, and those also who are from the hospital side, like Nashwa is from the South City Hospital. So let's start. I'll start you, sir, Aftab Sahab. What structure and cognitive factors most commonly contribute to the diagnostic errors that we make? And there are a number of diagnostic errors we all know. And how can healthcare team, not an individual, proactively mitigate them? What do you think? What do you think how it could be done?
I think the first thing to do would be to define diagnostic error for the sake of the public. And diagnostic error means when you cannot make the right diagnosis, or you miss the right diagnosis, or even if a diagnosis is delayed, that is also called a diagnostic error. And if even the diagnosis is correctly made, is made in time, and is not communicated to the patient in time, even that is a diagnostic error. So in US, about 12 million diagnostic errors took place 2 years ago in 1 year. And they were responsible for a number of deaths. Diagnostic errors, they come under the ambit of medical errors. And the medical errors were first highlighted in a report of Institute of Medicine, which was published in 1999. So I personally believe that these occur because we do not do what Sir William Osler asked the modern day physician to do. And he was a professor at University of Pennsylvania in 1905, beginning of the last century. And he said, listen to your patient. He is telling you the diagnosis. So unfortunately, we are more focused on clinical decision support systems and artificial intelligence, whereas in many prospective studies we know that the correct diagnosis can be made in about 75% cases on history alone, 6 to 7% on examination, and 13-14% on investigations. So if we employ the right history, spend quality time with the patient, examine, and become a thinking doctor. One important thing is, as we become senior, we stop at times to think and do things reflexly. And that contributes to diagnostic errors. Once the diagnosis is incorrect, then it erodes the trust. It jeopardizes the outcome of the patient. It causes extra burden on the cost. Medical errors, sir, are responsible for an additional cost on healthcare of $50 billion per year. So this is all preventable if we start with the right history, spend time with the patient, and if we have systems in place. Unfortunately, when we are overburdened with patients, we do not have systems. So first is the cognitive problem, that the physician herself or himself is at fault. Then are the systems. अब वो हमें कहते हैं कि जी EMR इलेक्ट्रॉनिक मेडिकल रिकॉर्ड होना चाहिए। आप बड़े बड़े ओहदों पर रहे हैं माशाल्लाह, and you have headed so many institutions, and now you are at the helm of the policy making in the province of Sindh, and with the status of a minister. So you should know that these doctors, EMR requires time. If you go to US and UK, a doctor is supposed to see only a maximum number of 10 to 12 patients in one day, because it takes 30 minutes to register the patient on EMR. तो एक तरफ expectation है कि EMR हो, दूसरी तरफ number of patients ज़्यादा है। फिर हम जब मांगते हैं as a physician sir, we ask for a data entry operator, तो वो कहते हैं नहीं ये आपने खुद करना है। तो बड़ी ही एक डायलेमा है। फिर दो चीजें और हैं, with the permission of the chair, I would like to highlight जो डायग्नोस्टिक एरर में सिग्निफिकेंटली कंट्रीब्यूट करती है। एक है हेल्थ डिस्पैरिटीज, और आपसे ज्यादा कौन अवेयर होगा कि जब मरीज आता है हॉस्पिटल में तो वो लोग जिनको सबसे ज्यादा जरूरत होती है केयर की, दे एंड अप रिसीविंग द लीस्ट केयर। I will highlight few examples. People who inject drugs, doctors, most of them look down upon them. ऐसे जैसे वो कोई जुर्म करके आ रहा है, वो तो बेचारा ड्रग एडिक्ट अपनी मर्जी से नहीं हुआ है, वो तो आपकी शफकत और मोहब्बत चाह रहा है। People who are left unattended, people who are poor and marginalized, people who are mentally challenged, people who are old and who have multi-morbidity, ये सारों को ज्यादा जरूरत है, और प्रिजनर्स, लेकिन इनको कम मिलता है। तो एक ये भी वजह है डायग्नोस्टिक एरर्स की और मेडिकल एरर की। और सर एक और वजह है, वो है ये सिस्टम कोई इंसेंटिवाइज नहीं करता। अगर कोई अच्छा काम कर रहा है या बुरा काम कर रहा है, वो सबके लिए बराबर है।
Dr. Naveed, continuing with what Aftab sir has बताया in a very nice, elaborative way, what errors are. Don't you think, as he has said, that right now we are emphasizing more on the diagnostic tools rather than applying our knowledge of medicine in the form of history taking, examination, which our professors used to emphasize a lot. And they were of the view that, as he has very correctly said, that majority of the diagnoses are made on that. Today, हमारे साथ जो लोग हैं, because of the availability of CT scan, MRI, so many things, the first thing we do is when the patient comes with, for example, a headache, MRI करा के आते हैं. Now taking an easy way out to diagnose, because we have got so much rush, we don't want to examine him properly for that. आप क्या समझते हैं, does it contributing to diagnostic error, and how can it be overcome?
Sir, thank you very much for giving me a chance to collaborate myself on such an important topic. So you are very right, sir. Said a very important sentence in the beginning that listen to the patient, he is telling you the diagnosis. So I personally feel that one factor is the patient's workload, because a doctor has to see a lot of patients in 3 to 4 hours, and the patient expects that the doctor should not only listen to him or her, he should also examine her and him and then prescribe the relevant investigation. But I personally feel, sir, keeping in view all these limitations, they are there, but one link is definitely missing, and that is we do not touch our patient. That sense of touch, that like we talk of the sense of touch between the mom and the baby, exactly the same relation exists between the patient and the doctor. This link is missing, and how we can re-establish this link, I don't know, because the patient to doctor number is too much. But I personally believe that this factor should be addressed seriously, and this should not only develop the patient-doctor, strengthen the patient-doctor relation, but it also decrease the workload on our investigation. Like, number one, the patient expects a doctor साहब को test ही लिखा, so doctor writes the whole battery of the investigation, including chemistry and radiology and everything. But if we start doing that, and if we start developing the rapport with the patient in terms of detailed history and clinical examination, and then full explanation to the patient, because once the patient leaves the patient office of the clinician, he's I don't know, मुझे तो नहीं पता डॉक्टर साहब ने कि मुझे क्या मसला है. So we should properly explain the patient, and it would definitely decrease the workload on our investigation to better investigation. As sir mentioned, I was reading a few days back, because it would also jeopardize the number of patients. It would also jeopardize the patient safety as well, which is our prime topic today. And recently I was reading an article in which it was mentioned that the number of deaths in USA, because USA and UK, they are the icons for us. We read the books written by their doctors, and it counts around 2 lakh a year because of the breach in the patient safety chain. And number two example of UK, the NHS budget rose almost to 40% in the last 1 to 2 years. So I personally believe, sir, highlighting the very true topic of this age. The number of patients is the main cause that our diagnostic battery of investigation rate is rising, and we are missing the link between the patient and doctor, because we cannot explain to him, we cannot examine to him.
Samad sahab, ye bataye ki because you are in digital, which is the latest thing like AI and other things, the companies, do you have any solution for the problem that has been raised for overcoming these diagnostic errors? Do you have that? Not only relying upon the diagnostic tool, because once the tool goes wrong, the whole management will go wrong. So, do you think that the recent trends that you are just talking about, bringing up together, can they be of any support in overcoming this decision making of a diagnostic tool not to go wrong?
Assalamu alaikum. Thank you so much, sir. First of all, we at Digitrends currently working on the AI solutions which we think can make a difference in patient safety. I will give you for example which I think is relevant, how AI and IT can make a big impact on patient safety. First of all, we are going to integrate it with our EMR solution. So currently in the conventional EMR, if doctor enter the wrong medicine, or if any medicine which is not suitable for the patient, he has the allergies or some kind of histories, doctor cannot go through all the EMR details every time, and he can enter wrongly some medicine which may affect the health of the patient. Our AI system can be integrated with the EMR, and it can, in the real time, stop the doctor that do not enter that kind of medication that can be harmful for the patient. This is the one example, and there are many other features which can be very helpful when AI will be integrated into the current AMR solution. The second example would be, we are currently working on the world first FDA-approved wearable ECG device. So currently what is happening, when the device is taking the ECG of the patient, it is transmitting the data to the mobile application, and that mobile application submitting that data to the doctor, who is actually manually reading the ECG, and then he is diagnosing and prescribing the medication over his whatever he sees over his diagnosis. Now, if we integrate AI into that in between, where doctor is currently diagnosing or checking the ECG, the AI system can do this automatically, and he can suggest, the AI can suggest either the patient needs immediate attention of the doctor, so it can send the ambulance, or through telemedicine, doctor can connect to the patient directly. So if we will integrate AI agents into this hardware monitoring system, healthcare hardware monitoring system with the patient and doctor, that AI can do the job of the doctor, the initial job of the doctor. So it can be make great impact as well. The third thing is that differential diagnosis tool. We are partnered with the leading differential diagnosis tools such as Visual DX. So we integrated that Visual Diagnosis. We launched that differential diagnosis tool here in Pakistan, we saw a very good adaptation on AI on that tool. If you take a picture of your skin region, the AI image recognition system can recognize either it's psoriasis or eczema through the thousands of images which is already stored in the database of the AI. And doctor who maybe he cannot diagnose that this is the early stage of psoriasis, AI can detect it in a very early stage. So these are the 3-4 examples which I think, and this is already happening in the world. AI has been integrated. The question is, we are not only trying to implement and integrate these solutions currently within this Pakistan market and in Saudi and in Dubai. We are also taking care how the AI governance and how AI compliances can be a part of it. So it can be implemented. Again, it's related to patient safety also. So I think AI will make a great impact, inshallah.
Thank you. Dr. Mema, my question to you, because you're also associated with the pharmaceutical, what prescribing safeguards are there for effective avoiding any prescribing liquidity or anything that can be a wrong prescription because you're associated with the pharmaceutical? What safeguard the pharmaceutical has done to them? For example, I can give you a number of medicines with a similar name, similar appearance. In cases of an emergency, sometimes the nurse pick up the wrong one, and it may be illegal for the patient. So, what are the safeguards that the pharmaceuticals taking in order to avoid these prescribing?
All right. Thank you so much. My name is Umema. Thank you for inviting. I am representing a pharmaceutical company here, but I also hold a position for a primary healthcare setup here in Karachi. So I have kind of an ambit or a cap of both, say it from a pharmaceutical perspective and from the hospital end as well. And there have been a lot of solutions that आपने AI की बात करी, and there are a lot of integrations. And same goes when it comes to patient safety, and we talk about what systems can be implemented in pharmaceutical companies. But before I can actually talk about what should be done, I'll be talking about a patient safety culture. And there is a small presentation, if you may all allow me to give a small presentation of the magnitude of patient safety which we are talking about, especially here in Pakistan. So, sir, if you may allow, I'll just give a brief presentation. It's hardly of 10, 11 slides.
Time, so we can just discuss that now. We can give us a brief description about that.
I'm sorry?
We are running short of time, so...
Okay. All right. So I'll just make it very precisely. For me, when it comes to ADR or pharmacovigilance, or we talk about reporting system, the first thing which has to come is to start reporting. We do not hold here a culture of reporting. DRAP already has established systems in which the healthcare providers and the people who are in the pharmaceutical companies are encouraged to report any ADR which is reported. And I'm talking about the drug reporting errors. I'm not talking about the medical errors, just as Dr. Saab ne initially kaha, that also comes under the ambit of medical error. But unless and until we do not know what is being reported and what are the root causes of it, how are we going to actually establish systems in our areas to counter that? And I'm sorry, I was not able to listen to your specific questions regarding pharmacovigilance.
Regarding the drug that we use, for example, recently, DRAP has withdrawn a serum because it was causing a lot of complications. Many medicines are withdrawn. So what pharmaceutical industry is taking care of avoiding those errors to take place when you are manufacturing a medicine? What are the protocols that you follow? Are there any protocols?
Yes, definitely. See, pharmaceutical companies, especially in Pakistan, I would consider this is the most regulated industry in Pakistan. And it has federal regulations applying to it as well as the provincial ones. So there are systems established. Say, for example, I'd give, an example of LASA, which is called as the lookalike enzyme, which is the major, one of the major causes of, wrong administration or wrong prescribing. And there is a whole system established by pharmaceutical companies, especially the MNCs as well as the local pharmaceutical companies, they have established systems in which they do have protocols, and especially with the integration of AI into such systems, we are able to check that. And similarly goes with the names. But unfortunately, I would refer to the recent cases of 𝐕𝐭𝐧𝐻𝐴, as we all are well aware. The case of ceftriaxone, we already know that. But these were malpractices of administration rather than something which was falling under the pharmaceutical category. So the indications are, of course, devised.
Thank you very much. Nashwa, you are related to a hospital, a major hospital in the city. So what do you think in a hospital? We all know there are so many cases reported, so many errors take place. We may at times life-threatening to the patient. Patients have lost life. So do you think, what are the major protocols that could be applied, or what are the systems that need to be in place in order to avoid all that what is unfortunately happening if patients are being mistreated or being misdiagnosed or whatever you say, which is harmful to the patient whenever they come to the hospital? Any protocols or systems that you think are there, or you will suggest them to be applied?
Assalamualaikum. Thank you, sir, for having us. Thank you for having us. So I work very closely with a lot of workflows with different kinds of healthcare providers, be them physicians or nurses. Now, in terms of reducing harm, there are different components to how you can reduce harm based on who the provider is. जैसे हमने आज की discussion में देखा है, the physician's perspective or the surgeon's perspective is very unique and different. They have different goals for the patient, be it their assessment, their diagnostics, the treatment plan. That is a vision which is dedicated to the physician. Where safety falls in, where measures fall in, where systems fall in to reduce harm in that pathway is separate. That is something that is addressed separately, that has different patterns, different safety measures. If we're talking about surgery, for example, something which may seem like a very simple process, but starting from when the moment the patient arrives in your clinic, what is being communicated, what is being documented, what is going on the record, what does the patient understand from everything the surgeon is saying? And in the event of a harm happening, was that harm pre-warned, pre-informed to the patient? Was it uninformed to the patient? What are accountability measures in place for the surgeon or for the providers? So, surgeons, for example, nursing is a completely different game. Nursing ka role is absolutely separate. They are more involved with the hands-on care of the patient in a time which is vaster than it is for the physician. How to reduce patient falls, how to prevent the patient from getting harm from regular activities while they're in the hospital setting, during mobilization, during eating, to prevent aspiration, for example, to prevent medication errors. What is the process of the medication cycle? Uske humne kaun se metrics, accountability tools rakhe to make sure medication is being given safely.
Also, being a physician, there are a number of times we are prescribing a medicine. A patient has got a problem. He says, for example, fala factor deficiency, yeah, I've got epilepsy. And when we are prescribing a medicine for that, not for that, for other reasons, we at times do not know whether this medicine will be harmful to that or is contraindicating that. So at times we miss, because no doctor can have knowledge about every disease and what medicines can indicate. Do you think the use of e-prescription could be effective in that, or still the use of our own intelligence in that will be more effective?
I think, sir, you have rightly pointed out, electronic medical record or e-prescription can help reduce it, magar it cannot eliminate it. Healthcare industry is supposed to be an industry which is far less regulated than many other industries like flying industry. People who are flying jets and airlines, they are far more meticulous in their approach, whereas the number of people suffering at the hands of medical error is far more. In USA alone, medical errors have become the third leading cause of death of them, there are 250,000 every year, half of them are preventable. And sir, 250,000 makes it about 680 per day. That is like 1.5 jumbo jet going down every day. And look at the time, look at the method, look at the money that is being spent on airline safety compared to healthcare safety in our profession. So something we are doing is absolutely wrong, and it requires a paradigm shift.
So what do you suggest? Like, as we have very correctly said, there are a number of prescribing errors that we are making. Even the most senior ones make an error in prescription, and they miss on the history of the patient because EMR is very good, it's a new thing. But practically speaking, as we have been working in the government sector hospital, the prescription when you write the government sector hospital and nobody with 300 patients standing and you have to pass within 3-4 hours, it's not possible to go for an EMR for each one of them. Either it should be a limited number of patients that we are seeing, but we are seeing an uncounted number of patients. उस condition के अंदर, what do you suggest? What protocol or what safety measures could be undertaken कि आप either it should be at the end of the prescribing doctor or the pharmacy which is issuing should take care of that when the pharmaceutical after prescription जाए that this drug should not be given to this patient or the dosage is not correct. What do you think? How could it be counteracted?
I think, sir, you have highlighted the issue in your own question that it cannot be anyone working in isolation. What we are doing right now is working in silos. Physician working as a physician, pharmacist working there. EMR, I don't think is going to be the solution in Pakistan. There are two things. I am an old school. I believe that if you spend quality time with the patient, that not only builds trust, it also ensures patient safety and it also ensures quality care to the patient. But at the same time, we have to think differently. The money cannot go to the armed forces of Pakistan and our patients deprived of their due rights. ये कहाँ पर होता है कि 1% GDP से भी कम हम एजुकेशन और 1% से कम हेल्थ पे खर्च कर रहे हैं. This thing will have to change if you want to change or contribute. अमेरिका में वो कहते हैं कि हम 2,50,000 लोग हमारे मरते हैं हर साल और वो कहते हैं कि 3 मिलियन लोग मरते हैं दुनिया में हर साल. पाकिस्तान में तो रिपोर्ट ही नहीं होती. इंडिया में 54 million medical errors take place every year, which is among us. So हमारे तो वो figures ही नहीं है. So we have to bring in more money, we have to bring in more resources. और वो पाकिस्तान के कहाँ से आएंगे? डेट सर्विसिंग से आएंगे, आर्म फोर्सेस से लेंगे. ये अभी बात हो रही थी सर कि प्राइमरी हेल्थ केयर पे पैसा नहीं लगाते और इंडस को 10 बिलियन दे दिया. भाई इंडस को 10 नहीं 20 चाहिए, मगर ये नहीं है कि वो ये समझते हैं कि इंडस से लेके नहीं लगाया जा सकता. इंडस को पहले ही ज्यादा चाहिए. आपको मजीद पैसा चाहिए और उसको लाना पड़ेगा in order to improve the health. Or EMR is not the solution, sir.
So what we conclude is that though these gadgets are very good, the EMR or the digitalization in Africa, but it is not this case you can have a blanket thing from the US coming to Pakistan and make it take. We have to cut it according to our own needs and our own requirements and our own problems that we have. सबसे बड़ा issue ये कि you don't have that much of resources available. जैसे कि रोबोटिक के वक्त सिंध में एक बड़ा हंगामा हुआ whether to buy a robot or not to buy a robot, costing billions of rupees. Whether that should be spent on a robot to be bought or that should be spent on primary health care. Because tertiary health care is given more emphasis upon in every part of Pakistan rather than the primary health care. जबकि दुनिया भर में मैं समझता हूँ प्राइमरी हेल्थ केयर ज़्यादा करें ताकि आपका पेशेंट ही ना है. क्लीन वाटर नहीं है आपके पास, सिविलाइजेशन की कमी है, दे ऑल बेटर. मैं नवीद साहब आपसे पूछूंगा, being a surgeon, we make a lot of errors. I am a surgeon myself. What checklist, team communication strategies, or data tools you will suggest that can avoid those errors that we make during our surgery?
Sir, so this is a very important topic, and I think this is all we being clinicians are meant for. The patient safety first. And these all checklists, they are meant for this purpose. There are many checklists. First is a WHO checklist, and the second is SURPASS checklist. Surgical patients safety factors. But sir, I personally believe before we go to the fancy checklist, we need to educate our healthcare providers. And actually, sir, we start with the top-down approach: consultants, and then senior residents, and then junior residents, and actual. The main stakeholders, in my opinion, they are the nursing staff. You may agree or not that most of the time spent with the patient is by the nursing staff. So checklists are there, sir. Definitely, like WHO checklist. WHO checklist, sir, is basically is meant for mainly in the operating room, before induction and before NCM and before the patient leaves the operating room. It mainly encompasses all that horizon while the patient is inside the operating room. Actually, sir, the safety starts right from the clinic of the clinician. When the patient visits the clinic of the clinician, the safety measures need to be adapted. In the case of preoperative care and then followed by intraoperative and then postoperative care. And the whole scenario is encompassed by the one term that is called these days as perioperative care. So in my opinion, in preoperative care, we should emphasize on detailed history. Actually, sir, I would conclude in one line: go back to the basics. Actually, sir, we have left the basics, and we have done like sir said, like electronic medical records and like EMS system and EMR system, everything. It looks very fancy. It fantasizes someone. We are like advancing in every field, but we have no money with us. So we will have to go back to the basics. We will need to take the detailed history and examine the patient and then assess the comorbids and do a detailed and good pre-anesthesia assessment before the patient is subjected to surgery. And likewise, while the patient is in the ward the night before the surgery, I personally believe no doctor goes to the patient to document the things like which side is to be operated upon, whether it is right side or left side, where the stoma is supposed to be formed. This is done by nursing staff. Like, and the consent form is put in front of the patient. Please just sign kar dein. What is written in that consent form? Neither the staff nor the patient and nor the tenders don't know anything. So, sir, in my opinion, these checklists, they are very good. But after once we have done our homework, we have taught our basic stakeholders in the wards, in the hospitals, in the OPDs, and then, sir, in the operating room, mainly WHO checklist. Definitely, if it is emphasized in true letter and spirit, it can avoid so many avoidable medical accidents, right, sir? And then, obviously, post-operatively, in the theater, the main stakeholders are an anesthetist and followed by the surgeon. And then post-operatively, again, the surgeon operates and he endorses the notes, and the whole night patient spends with the nursing staff. And the nursing staff, the ratio must be 60:1 or maybe 60:2. And I think, sir, basic homework needs to be improved.
I think as a professional, medical professional myself, we are the least accountable people. We make errors in our practice, we make errors in the hospital, we make errors in diagnosis, and nobody is accountable. हमारे जो patient है, मेरा जो experience है, they are so thankful to you even if the patient dies. ये कहते हैं अल्लाह की मर्जी थी डॉक्टर साहब आपने तो बहुत मेहनत की. उन्हें ये नहीं पता कि मेहनत जो है वो गलत हुई या कैसी हुई. They are always thankful to you, 99% of them. Maybe 1% of them they don't. Don't you think a medical audit should be done in every hospital regularly, honestly? And that should be published. And I remember when I was working as a registrar in UK, Bristol के अंदर audit हुआ, पता चला जी cardiac surgery में इनका जो mortality rate है पूरे यूके में सबसे ज़्यादा है. They stopped cardiac surgery in Bristol Hospital. In February में रोक दी. They asked the cardiac surgeon to go for a refresher course, improve the capacity, come back and do start it again. Unfortunately, we are not accountable. So, how do you suggest hospital की कैसे accountability करें? So many errors are done in the hospital. Patient passes away. They even sometimes they complain, but they cannot do anything. Diagnosis के अंदर होता है दवाइयाँ आप मेडिसिन फार्मास्यूटिकल वाले दवाइयाँ गलत मिलती हैं. अभी आपको पता ही होगा कि मेडिसिन विड्रॉ की है गवर्नमेंट डी-ड्रैप ने कितनी सारी मेडिसिन विड्रॉ की है बिकॉज वो पूरे के पूरा जो आपका सीरियल नंबर था उसकी मेडिसिन गलत थी, उसके अंदर रेशियो गलत था. एंड वी आर नॉट अकाउंटेबल. व्हाट इज बीन डन, नोबडी हैज बीन punished, neither a pharmaceutical company nor a hospital nor a doctor. तो आप लोग इस पे क्या टेक है सर? मैं आपसे शुरू करूंगा, then we'll go to everyone.
I would like to share an interesting statistic with your permission from USA. When they started this audit, supporting your point, they said that the wrong site, wrong procedure, and wrong patient was running in thousands. And in 2018, wrong procedure and wrong site and wrong patient was brought down to 90, just 90 in the entire US. Just by putting those protocols, जो कह रहे हैं. अब जब मैं USA में ट्रेन हो रहा था, तो जब भी टीका लगाते थे, तो भरने से पहले नर्स बोलती थी कि डॉक्टर मोहसिन इंजेक्शन नेम, एक्सपायरी डेट और उसकी स्ट्रेंथ क्या है, और हम उसको वेरीफाई करते थे. और फिर हर IV was given by the physician. Nurses were not supposed to give IV. अब वहाँ पे नर्स प्रैक्टिशनर्स आ गए जो देते हैं, उस वक्त अलाउड नहीं था. तो we have to change the system, we have to introduce the protocol, and we have to rethink the way we treat the patient. You are absolutely right. If you have communicated to the patient properly, they are always very thankful, even when the outcome is not desirable. So we have to, and sir, I think मैं बार-बार एक ही बात कर रहा हूँ. Old school, proper history, spending quality time with the patient, examining the patient, and we must realize that when we order investigations, first they are expensive, and about 10% results are not correct. They are faulty because of the process. So we cannot rely 100% on investigation. So the basic thing is important, and we have to do more protocols, more time with the patient. We have to be more strict.
Now, Naveed, this medical audit of a hospital, sir, is it a good thing to be done? Does it need to be publicized? Publish किया जाए, लोगों को पता चले. Though it may be a very difficult thing for a hospital to accept that so many errors have been done, but don't you think that is better for the safety of the patient in improving our system?
So it is not a good thing, it is a must-do thing. Because if we don't report an error, if we don't publish an error, how can we improve ourselves? Because if one patient suffers today, the next patient will suffer again. So I think the basic reasons why we don't report the facts is, number one, there are so many stigmas involved in this matter. This is like social factors. Maybe it's a blame culture. Like doctor will think that everyone will point towards me. यार इसने देखो ये काम किया, इस वजह से पेशेंट मर गया, इस वजह से वो मोर्बिडिटी बढ़ गई है. And then secondly, sir, might be the reporting might be hidden because of the involvement of the hierarchy. Might be there is involvement of very senior clinician in this error. So hospital and the staff, they will try to like hide the thing and then let it go as it is going on and let the patient suffer. And thirdly, sir, the process of documentation and the process of error reporting has been made so difficult. In my opinion, I have seen a form of quality assurance department of an hospital. It was so complicated, it was so difficult to read, and it was so difficult to comment upon that everyone would like to avoid it. Here is sir. And if someone reports, suppose I have seen something and I visit you for another reason, मैं आपसे कहूँगा सर मैंने एक चीज देखी है, but keep it up to you only. Don't mention it somewhere. So we try to hide because things have been made difficult, and there is always a risk. In the back of mind, there is always a fear of the litigation that I may lose my job, and then it will act as a stigma for me for the rest of my life. So, sir, until and unless we don't report the fact, how can we improve ourselves? Because there is always a room for improvement, and if you don't accept it, we cannot progress. It's a must do this.
समझ आप ये बताएं कि आप डिजिटलाइजेशन के ऊपर एम्फसाइज कर रहे हैं, आपने सिमुलेटर्स बनाए हैं फॉर चिल्ड्रन फॉर न्यू यंगस्टर्स टू लर्न ओवर देम. डू यू थिंक कोई आपके पास ऐसा एआई है, कोई ऐसा डिजिटलाइजेशन टेक्निक है जो कि इन एरर्स को, जो कि हम कहते हैं कि मेडिकल ऑडिट के अंदर सपोर्ट कर सकते हैं और वो सपोर्ट कर सकते हैं सिस्टम को टू ओवरकम दीज एरर्स दैट वी आर डूइंग? डू यू हैव एनी सिस्टम लाइक दैट?
सर वेस्ट में एक टर्म इस वक्त इवॉल्व हो रही है, दैट्स कॉल्ड डिजिटल हेल्थ ऑडिटर. डिजिटल हेल्थ ऑडिटर करंटली इट इज़ वेरी इनिशियल स्टेज, बट व्हाट इट विल डू द हेल्थ ऑडिटिंग रियल टाइम, मीन्स फ्रॉम प्रिस्क्रिप्शन. जैसे कि आपका पहला सवाल था कि हमें इसको ना सिर्फ हॉस्पिटल में, क्या हमें इसको केमिस्ट के पास भी इम्प्लीमेंट करना चाहिए. So it will be connected all over the touch points of the patient, from taking the appointment to doctor, to medicine, to therapy at home. All the touch point will be monitored through the digital health auditor. That digital health auditor would be an AI agent and AI tool, comprehensive AI tool with all the data of the patient, complete history, all the data of the medication. जैसे अभी आपने बोला कि कुछ medication जो थी वो expire हुई थी, उनके serial number, तो उसमें all the data of the medication from the factory, all the medication, all the history of the patient, all the history उस डॉक्टर की जो प्रिस्क्राइब कर रहा है, कहीं वो अपने किसी ऐसी मेंटल स्टेट में तो नहीं है. सो मैंने इसको रिसर्च किया था, एंड व्हाट आई बिलीव, आई एम वेरी होपफुल कि इट्स अ मैटर ऑफ टाइम कि अभी करंटली हम पाकिस्तान में जो इश्यूज फेस कर रहे हैं, आई थिंक इन नेक्स्ट 10 ईयर और 15 ईयर दीज ऑल इश्यूज विल बी एलिमिनेटेड. हमारे कुछ और इश्यूज होंगे उस जमाने के AI को लेके, कुछ और चैलेंजेस होंगे, कुछ और थ्रेट्स होंगे, आई रादर से. बट ये जो हमारे करंट इश्यूज हैं, इट्स अ मैटर ऑफ टाइम, क्योंकि टेक्नोलॉजी अडेप्टेशन इज वेरी फास्ट. इवन इन पाकिस्तान यू कैन सी कि जब आईफोन वहाँ US में लॉन्च होता है तो आईफोन यहाँ भी आ जाता है. दो इन हेल्थ केयर, जैसे सर ने बोला कि हमारी बजट्स वगैरह कम है और हम उस तरीके से जो है वो इम्प्लीमेंटेशन नहीं कर रहे हैं. हमारे पास एक सेंट्रलाइज EMR सिस्टम फॉर द कंट्री वाइड नहीं है अभी तक, अनफॉर्चुनेटली. बट आई थिंक इट्स अ मैटर ऑफ टाइम. टेक्नोलॉजी विल बी इवॉल्व, टेक्नोलॉजी विल बी इम्प्लीमेंटेड, एंड दिस डिजिटल हेल्थ ऑडिटर विल बी द आंसर ऑफ सो मेनी प्रॉब्लम्स. दैट्स व्हाट आई बिलीव. होप आई आंसर द क्वेश्चन.
Dr. Mema, being a pharmaceutical representative, I'll just ask you one thing. कि जैसे हम मेडिसिन की बात कर रहे हैं कि डॉक्टर्स की ऑडिट होना चाहिए, उसको जो है पब्लिश होना चाहिए, क्या आपकी फार्मास्यूटिकल इंडस्ट्री के अंदर कोई ऐसा सिस्टम है? रेगुलेटेड तो आप कहेंगे है, आप ड्रैब से रेगुलेटेड है, लेकिन द प्राइम मिनिस्टर वाज सो अपसेट यस्टरडे कि उन्होंने कहा है कि ड्रैब का नाम ड्रग रेगुलेटरी अथॉरिटी की जगह डिले रेगुलेटरी अथॉरिटी की जाए, कि जो चीज़ दी जाती है, तो प्राइम मिनिस्टर सेड कि आई एम सो अपसेट विद दैट ड्रैब. सो आई एम नॉट गोइंग टू द डिटेल्स ऑफ दैट. मेरा ये पूछना है कि कोई आपकी अपनी फार्मास्यूटिकल कंपनी का कोई कोड ऑफ कंडक्ट है, कोई ऐसी चीज़ है कि आपके यहाँ कोई फार्मास्यूटिकल कंपनी इफ मेक्स एन एरर और समथिंग लाइक रिसेंटली इट हैज बीन डन, तो आप लोग अपने ओन पाकिस्तान फार्मास्यूटिकल एसोसिएशन के प्लेटफॉर्म पर कुछ करते हैं, पब्लिक अवेयरनेस के लिए कुछ करते हैं लोगों को? क्योंकि मैंने नहीं कभी देखा कि कोई आपकी तरफ से कोई ऐसा पब्लिक के लिए आया हो कि ये फला मेडिसिन जो इसकी साइड इफेक्ट्स हैं, इनको ना यूज़ किया जाए, या ये मेडिसिन, वो तो गवर्नमेंट को ड्रॉ कर ले तो अलग बात है. डू यू हैव एनी कोड ऑफ कंडक्ट फॉर दिस?
Sure. Okay. Luckily, pharmaceutical companies, especially who are going in the international market, they have to comply with certain regulatory requirements, of course. और हमारे पास regulatory requirement है, लेकिन of course the pharmaceutical companies have been getting away with it because the enforcement was not as such. But over a period of 1 decade, especially in the last 5 years, DRAP regulation for pharmaceutical companies have been very stringent. So yes, of course, we do have a system. What I can always, I would not be able to comment on what other pharmaceutical companies are doing, but I would be able to comment on what protocols and procedures which we have adapted in our pharmaceutical companies, due to which we were able to get WHO certification. And I think Pharmivo is the only company which has gotten WHO certification globally for 2 of its molecules. So I think वो मैं practices जरूर share कर सकती हूँ जो हम करते हैं. So regarding pharmacovigilance, yes, the drug inserts which we have for our patients, we do have a reporting email address. We do have an online. Yeah, sure. Okay. So we do have an online reporting system where a patient, irrespective, can report. And in the last 10 years, it's been like 11 years since this system has been established in Pharmivo. We have reported our ADRs to the DRAP, but unfortunately, the number is not that high that we can actually detect a signal so that it can be of any value. But we do have our 3,000 field force trained on pharmacovigilance, starting from Karachi to Mardan. So yes, we do that. We have our protocols.
I would disagree with ma'am with due deference. I will quote incidents which occurred in Lahore. The year was 2011, and the Lahore was seeing the highest epidemic of dengue anywhere in the world. And we had about 400 or 500 deaths, and I was working in Services Hospital as head of the medical unit, one of the units. So we started receiving patients who were very similar to dengue, but no fever, and they were having low platelets and they were dying. And even the platelets were not very low. So what transpired after 2 or 3 months was they were all people from Punjab Institute of Cardiology, which is beside us. They were all receiving isosorbide nitrate medicine produced by 𝐼𝐻𝐢𝐹, and they were all dying because somehow they had put pyrimethamine in those, and they were dying of bone marrow failure. And it took us many weeks. We found out that it was responsible. So all drugs were withdrawn from PIC pharmacy. And then they were sent. Pakistan में there was no system, और अभी भी नहीं है. We find out कि क्या वो pyrimethamine was diagnosed in UK, और फिर उन्होंने हमें बताया कि इसका ये एंटीडोट है, वो हमने दिया. तो अनफॉर्चुनेटली कोई सिस्टम है नहीं अभी तक.
मैं आपसे बिल्कुल एग्री करूंगा. मेरा मकसद ये था कि कोई ऐसी वेबसाइट नहीं है आपकी फार्मास्यूटिकल कंपनीज की कि उसको आदमी विजिट करके देखे कि भाई इसके अंदर कौन कौन सी दवाइयों में रिएक्शंस हो रहा है. कोई आप इंफॉर्मेशन पब्लिक को नहीं देते. और अब जैसे आपने एक कंपनी का जिक्र किया कि इनकी वजह से थोड़े लोग नहीं मरे, सैकड़ों में लोग मरे, जो आप बता रहे हैं. क्या हुआ? क्या हुआ? कुछ नहीं हुआ.
10 साल बाद वो कंपनी दोबारा चल पड़ी है सर.
कुछ नहीं हुआ. तो वही मैंने आपसे कहा कि हमारे
can I also add on? Not differing to your opinion, not conflicting that, but we have to look at from the different tangent as well. The case which you're referring of PIC, of course, everyone remembers that it was, if I remember the numbers right, it was given to 40,000 patients, if I'm not wrong, and 100 died, and they were not able to be identified for over a period of 1 month. Now, yes, the cross-contamination was there. It was a local pharmaceutical company. They were penalized as well. The whole team was fired because of that case. And the case went into the High Court as well. But we also need to look on, I think, the people working in that pharmaceutical company responsible. Ji, sir?
Fired. What do you mean?
No, this is what I got to know. I'm not a part of, I have never been a part of that company, so I don't know. But my only submission is that we need to look at from the other perspective. The hospital also did not have a proper recording system. The hospital did not have a quality system as well.
So, आप बताएं कि ये जो प्रॉब्लम है ये खाली फार्मास्यूटिकल या मेडिसिन में नहीं है. हॉस्पिटल्स के अंदर भी there are a lot of complaints and you are fully aware of that. Many hospitals, patients die because of the care not being given, not being taken properly treated, misdiagnosed during an ER, ER is not fully equipped. So many issues in hospital. I'm not talking about any one hospital, I'm talking about all the hospitals in general. And no hospital can be said to be an ideal hospital to go to. So, do you people you have got an association of private hospital association? मैं गवर्नमेंट की इसलिए बात नहीं कर रहा, गवर्नमेंट का तो अपना सिस्टम है. तो क्या आप लोगों ने कभी अपनी एसोसिएशन की तरफ से किसी हॉस्पिटल को डिमार्च किया है, किसी का कोई वेबसाइट बना के लिखा है कि जी हॉस्पिटल के अंदर ये चीजें? Why is it that you scratch my back and I scratch your back?
Sir, if you look at it, if we're only talking about private hospitals, because public hospitals is a totally,
पब्लिक का तो हमें पता है ना,
different.
वो तो हमें मालूम है.
If we're talking about private hospitals, then transparency is an issue in our culture. We don't want to reveal what our errors are. Unfortunately, what it seems like our medical audit only happens based on reported negative outcomes. We're not looking at all the patients. We're only concerned with, जैसे आपने बोला कि मरीज को पता ही नहीं उसके साथ अच्छा हुआ है, बुरा हुआ है, but he's thankful. They don't know if any harm has actually happened. Maybe that harm is not palpable, but we react to a negative outcome which has been reported. The US has capitalized on this, and उनका जो payment model है, the insurance company, that is doing the audit for them. And why that is a good driver? Because the hospital is not going to get paid. The provider is not going to get paid unless he's able to prove that he has not caused harm to this patient. Unfortunately, we as humans, money has been a very important driver for performance. And maybe for us right now, money may still be a driver for performance. Unless you hold the money, nobody is going to come up to the line. And I feel like that is perhaps the only thing that will force hospitals to reach the mark, for providers to reach the mark. And unfortunately, we don't have patient advocacy. None of us are advocating for the patient. We're all advocating for our own siloed self-interest.
Sir, I was working as the program manager for hepatitis prevention and control. I was head of the Prime Minister program in Islamabad, 2009. So there was this guy who came from Center for Disease Control, USA, Atlanta. तो मैंने कहा कि ये क्वैक्स बड़ी हेपेटाइटिस सी और बी फैलाते हैं पाकिस्तान में, तो इनके लिए कुछ करते हैं. तुमने मेरे साथ कल प्राइम मिनिस्टर को मिलने जाना है, तो उसको ये कहना क्वैक वाली बात. कहता है आफ्ताब, you must put your house in order first. Most of the hepatitis C and B is spread through healthcare workers who are qualified and healthcare facilities that are regulated. क्वैक तो बेचारे बहुत कम करते. Pakistan uses more than 1 billion injections and we sell about 700 million syringes. यानी कि 300 मिलियन का तो यही फर्क है कि हम रीयूज कर रहे हैं. उसके बाद पिछले 3 महीने में सर, I have seen 3 cases of acute hepatitis C. 2 of them were operated in a private hospital and 1 in a public sector. So infection control is a huge problem and we are doing very little about it, and we must do much more, and I think we have to work together.
So that is what I'm trying to emphasize upon, that patient safety is not only related to the doctors, it also involves the pharmaceutical companies, it involves the hospital. Everybody has a share to take into it. And it cannot be this that the doctor is responsible, and nurse is responsible, and technician is responsible. Everybody has to play his role. We are all responsible. And the state of affairs that we see today, unfortunately, is a result of a decline. But I have been there for the last 35 years, from the house job that started. I can say that right now, what I see has been a decline in the standards of patient care, what I have seen when I was working as a house officer, as a resident. Unfortunately, at that time, what decline has taken place, not in the equipment, the decline has taken place in the empathy that we have for the patients. Unfortunately, at that time, we felt more, our professors who used to train us were more concerned. They go to the OPD on time, they go to the surgical theatre time. आज हम देखते हैं कि वो empathy नहीं है, वो feelings नहीं है. Why is it so? क्या हो गया हमें कि हम as a human being, not as a doctor only, we have lost the touch with our patients. वो जो एक bonding थी, एक binding था patient के साथ, आज वो नहीं नजर आ रहा. So how can we add that I was just discussing it with the Higher Education Commission Islamabad and PMDC. We had a meeting. Should we start an ethical course in ethics in medical and course के अंदर ऐड करें? लेकिन ethics को किसी कोर्स से पढ़ाकर ethics आप बना नहीं सकते. मेरा अपना ये ख्याल है. Ethics comes from your own family upbringing. बच्चा जब देखता है तो क्या हमारा upbringing के अंदर फर्क आ गया? Just एक मिनट आप लोग अगर इसके ऊपर कुछ कहें कि why we have lost that binding with our patient.
मैं वाकया आपसे बहुत गुजार करूँगा. मुबशर हुसैन मलिक साहब वाइस चांसलर थे यूनिवर्सिटी ऑफ हेल्थ साइंसेज के. 2002-03 की बातें हैं. आई वॉज अपॉइंटेड एज फर्स्ट कंट्रोलर तो ऑफ यूएसए. एक साल जब गुजर गया तो उन्होंने कहा आफ्ताब हम क्या करते हैं कि जो बच्चा मैट्रिक और एफएससी करके आता है कहता है मैं मुल्क और कौम की खिदमत करूँगा. जब डॉक्टर बनता है तो वो कहता है मैं स्पेशलिस्ट बनूंगा, मैं बेहतरीन सर्जन बनूंगा और मैं जो है अपना बेहतरीन क्लिनिक बनाऊंगा या अदारा बनाऊंगा या रिसर्च करूंगा. हम ऐसा क्या करते हैं 5 सालों में कि वो बच्चा एम्पैथी से सेल्फ पे आ जाता है, सेल्फ ग्लोरी. तो ये बाकी आपकी बात सही है कि इसके लिए कुछ करने की ज़रूरत है सर. और इसके लिए रोल मॉडल और मेंटरिंग और अप्रेंटिसशिप मॉडल जो पुराने ज़माने का कि वो जो मुर्शद के साथ उनको लगाना पड़ेगा, जो देखें जो करें. अगर वो हमारे जैसों को देखेगा तो बुरा ही हाल होगा.
नवीद आप कुछ?
Sir, I think this thing cannot be induced in somebody by some courses or by some lecture or anything. It is in your traits, it is in your genes. One brings the ethics and mannerism from his or her home actually. How he's brought up. So very rightly said. At a certain time, one is empathetic. After that, there is a certain, like, it's not even plateau, there is a certain decline. Even if he or she remains at some plateau for some time, it is acceptable. But you reach at the peak of the empathy and then suddenly you drop down as a nosedive, it is not acceptable. It means that there is something grossly wrong with the society. Because you cannot induce these things by courses and anything. This is my opinion, sir. And secondly, sir, do I learn to be empathetic while I am in some social gathering? I am empathetic, I am sympathetic, I am well-mannered. Has somebody taught me to be empathetic while I am talking to my parents? While I am talking to myself? Why there is an issue while me as a clinician is talking to the patient? Why then suddenly I minus this thing from my brain or from my body, from my genes, or from my brain. So we need to be taught, we need to be educated as a whole, as a society, not as clinicians only.
समझ आप ये बताएं क्योंकि आप डिजिटल में कि क्या ये मशीनों की जो जिंदगी आई है क्या ये जज्बात की मौत है कि जो हर चीज़ इक्विपमेंट मशीनें तो वो फीलिंग जो थी वो इसकी वजह से तो मुतासिर नहीं हुई है. मतलब मेरा मकसद ये कि जो हमारी एम्पैथी थी, जो मरीजों के साथ हमदर्दी थी, अब हर चीज़ डिजिटलाइज हो गई है, AI आ गया है, पेशेंट से कांटेक्ट जो है वो कम से कम हो गया है. जैसे कि अभी आफ्ताब साहब ने भी कहा था कि आप हिस्ट्री देते थे, बैठते थे, डिस्कस करते थे. अब तो हर चीज़ ये है कि डिजिटल है, MR, CT स्कैन, अल्ट्रासाउंड, ब्लड टेस्ट, ये वो. तो ये जो कांटेक्ट कम हुए, जो मशीनरी चीज़ें आ गई हैं, क्या ये एक रीज़न है कि हमारे फीलिंग्स जो है वो कम हो गई?
सर आई थिंक द प्रॉब्लम इज एजुकेशन.
एजुकेशन तो वक्त के साथ साथ तो ज़्यादा नॉलेज आ रही है, ज़्यादा चीज़ें प्रोग्रेस कर रही हैं.
सारे
कौन सी एजुकेशन?
सारे देखें, पेशेंट की खुद की एजुकेशन सबसे पहले, फिर जितने भी जैसे केमिस्ट बैठे हुए हैं हमारे पास वो समटाइम सर्टिफाइड नहीं होते. हमारे पास जितने भी टच पॉइंट्स हैं जहाँ हम थेरेपीज ले रहे हैं या जहाँ हम एडमिट हो रहे हैं, अगर हम एक लेट्स से वी पुट एवरीथिंग ऑन गवर्नमेंट एंड इट्स ऑफ कोर्स ये गवर्नमेंट की जॉब है करने की, बट लेट्स से कि अगर गवर्नमेंट नहीं कर पा रही, दे हैव इवन बिगर इश्यूज टू हैंडल. हम एज अ नेशन, ये सोशल मीडिया का ज़माना है, हमारे पास जो एक्सपर्ट्स कर रहे हैं कि हमारे पास PPMA है फॉर फार्मास्यूटिकल, हमारे पास हॉस्पिटल की अपनी एसोसिएशन है, हमारे पास केमिस्ट की अपनी एसोसिएशन, ये सारी एसोसिएशन मिलके इफ दे कैन रन अ कैंपेन ऑन सोशल मीडिया फॉर दिस काइंड ऑफ अवेयरनेस टू एजुकेट पेशेंट इटसेल्फ सबसे पहले एंड देन ऑल द स्टेक होल्डर्स फॉर पेशेंट सेफ्टी. पेशेंट सेफ्टी की ज़्यादा बात नहीं होती अनफॉर्चुनेटली पाकिस्तान में. तो पेशेंट सेफ्टी के ऊपर अगर हम सबसे पहले एजुकेट करें और अपनी जिम्मेदारी समझ के एजुकेट करें फर्स्ट. सेकेंड, इफ देयर इज अ वे टू मोनेटाइज इट, टू मॉनिटर इट, कि अगर आप इसको कर रहे हैं तो आप शायद किसी ना किसी तरीके से आपको इंसेंटिफाई किया जाए। थर्ड, टू अडेप्ट टेक्नोलॉजी ऑन इट, जैसे कि मैंने बोला डिजिटल हेल्थ आपका ऑडिटर अगर आ जाए तो। सो आई थिंक कि अगर हमें एजुकेट करें और इसकी अवेयरनेस ज़्यादा, जैसे आप लोग अभी माशाल्लाह कर रहे हैं, पेशेंट सेफ्टी के ऊपर आप लोग एक सेशन कर रहे हैं जो कि बहुत कम होते हैं। लास्ट ईयर भी, इस ईयर अर्ली भी एक हुआ था खान में, आई वाज पार्ट ऑफ दैट डिस्कशन एज वेल। सो मैंने देखा है कि पेशेंट सेफ्टी पे बहुत कम बात होती है, इतनी ज़्यादा अवेयरनेस नहीं कराई जाती, और ये बड़ा मतलब ये कि मेन एक्सपेक्ट है फेटल डेथ्स का। तो इसके ऊपर ज़्यादा से ज़्यादा एजुकेशन, इसकी अवेयरनेस, आई थिंक इट विल क्रिएट अ हेल्थ। और आपके क्वेश्चन का जवाब कि क्या ये जो हो गया, थैंक यू
जी। उमैमा, आप इस पर क्या कहेंगे कि ओवर द इयर्स ऑफ टाइम एज पासिंग बाय, the binding between a patient and a doctor and the feelings, have they decreased or they still the same, or do you think they have improved upon?
I think the human element, especially when it comes to healthcare industry, would never be able to eliminate it. I don't think so. There would ever be a time. जैसे सर ये बात करते हैं ना कि I have a conventional mindset that you still need to spend time with your patients. I would agree to that. And yes, with the passage of time, there would be technologies which we would have to adapt. But the human element, the empathy which is required when we talk about healthcare system, I think that would never be replaced by machines. So I think अभी जब हम बात करते हैं, अमेरिका की बहुत सारी researchers की भी बात करते हैं, so they are saying by 2030, a lot of the jobs which are today would be redundant by 2030, but the jobs which are still going to be there would all be related to the human elements.
आप कुछ कहेंगे ना?
Sir, just one small thing. Technology is meant to assist us, not replace us. It's meant to give us more time to do things which still provide value, such as giving face-to-face time with our patients. While everything else has been made fast for us, then we can slow down and listen to what they want to say and have that human connection. That's all we need.
How can ADR, the alternate dispute resolution, surveillance be strengthened at institutional and national level to support the proactive pharmacovigilance, that is the drugs-related problems?
I think, as you have said, audit, if you make ADR reporting compulsory, it builds in audit, it builds in transparency, it builds in accountability. और पहले ये जैसे सर ने कहा कि AI और ये चीज़ें करेंगी, तो एक बड़ा अच्छा सिस्टम है यूके में, हालांकि वो इतने टेक्नोलॉजिकली एडवांस नहीं है, वो है पीयर रिव्यू। जैसे आपने फरमाया कि ऑडिट होना चाहिए, पीयर रिव्यू इज एन ऑडिट and it brings in transparency and accountability at the same time. And I think American doctors and British doctors are far more empathetic than doctors in Pakistan. क्योंकि जब हम बाहर जाते हैं, मैं तो देखता हूँ, I am amazed the way they feel for their patients, the way they work for their patients, and the way they stand for their patients. तो मेरी रिक्वेस्ट होगी आबिद शेख साहब से और आपसे सर कि जैसे पेशेंट सेफ्टी पे बात हो रही है, अगली जो है एक्सपो में एम्पैथी पे जरूर बात हो, एक सेशन होना चाहिए कि इसको कैसे बिल्ड किया जाए और साइकियाट्रिस्ट को हम इसमें इन्वॉल्व करें या जो भी है। तो दैट इज माय हम्बल सजेशन सर।
नवीशा भी बताएं, करंट रिपोर्टिंग सिस्टम्स जो है हमारे, आर दे एक्सेसिबल इनफ टू द फ्रंट लाइन स्टाफ जो हम रिपोर्टिंग्स करते हैं? आर दे अवेलेबल? Are there any availability on the website or anything? या हमारे अपने staff जो होते हैं, is it available to them?
I personally believe they are not available.
They are not available.
Most of the hospital staff, they are not even aware of availability is a secondary issue. They are not even aware of that. There is some system existing in our hospital where we have to report some error that has happened in a hospital. And if at all it is available, if at all they are aware as well, I think they're not trained how to report, number one. And number two, as I said earlier, there is always some fear of reporting this, fear of maybe losing job, fear of maybe litigation, and fear of maybe getting a bad reputation. So I think they are not easily, if at all they are available, they are not known to the people in the hospital. I think it should be made easily, and it should also be, like a topic is there, the reporting should also be made easier and digitalized. easier to report, and it should be taken, the recipient should take it positively, not to penalize it, but for further improvement in the patient care.
समझ ये बताएं कि which digital health innovations that you people are doing, from AI triage to barcode medication administration, are making the greatest impact on patient safety today? Which one of them? Which could be applied for patient safety? Are these barcode medications or
yes,
AI
for
triage?
medication, barcode was already there for दवाइयों की ये चेक करने के लिए कि काउंटरफिटिंग ना हो रही हो, barcode was already there. Then there are other system to validate, but AI, I think I would rather say कि जो manufacturing में जब से इस्तेमाल होना शुरू होगा ना, अभी currently AI मेडिसिन की प्रिस्क्रिप्शन मैन्युफैक्चरिंग के टाइम पे स्टार्ट होना शुरू नहीं हुआ. इसी तरीके से बहुत सारे AI के एडेप्टेशन में प्रॉब्लम ये आ रही है कि गवर्नेंस और कंप्लायंसेस बीच में आ रहे हैं. सो आई थिंक करंट सोल्यूशन सारे सॉल्यूशंस जो हैं वो हेल्प कर रहे हैं. उसकी इम्प्लीमेंटेशन जो है वो वाइडली होनी चाहिए और स्मूथ होनी चाहिए, अकॉर्डिंग टू कंप्लायंसेस होनी चाहिए. बट एस आई एम वेरी होपफुल. मैंने पहले भी ये कहा था कि 15 इट्स अ रैपिड इनोवेशन हैपनिंग ऑल ओवर द वर्ल्ड. मतलब इतनी स्पीड से हो रही है. आपके सामने ही अभी ChatGPT आया है, चेंज द वर्ल्ड फॉर बहुत सारी चीज़ों पर उससे फर्क पड़ा है. और ये हम देख रहे हैं. जब ये ChatGPT पिछले 10 साल से 15 साल से बन रहा था तो इसका इम्पैक्ट एक नॉर्मल हम लोगों तक नहीं आ रहा था. अब इसका इम्पैक्ट आना शुरू होगा. तो अभी जो चीज़ें हो रही हैं जो कि इम्प्लीमेंट हो जाएंगी अगले 10 साल में, आई थिंक every aspect of healthcare will be revamped and all this problem will be solved. But again उसके बाद दूसरे issues हो सकते हैं which will be timely addressed.
डॉक्टर मेमा, आप ये बताएं कि पेशेंट सेफ्टी के लिए फार्मास्यूटिकल कंपनीज do say they play a very important role. मैं एक छोटा सा एग्जांपल देता हूँ कि अगर आप बाहर कोई मेडिसिन खरीदते हो, सिरप वगैरह, तो स्पेशल उसकी बॉटल का खोलने का वो होता है, कैप होता है, ताकि कोई बच्चा खोल के ना इस्तेमाल करे. पाकिस्तान में आप लोग नहीं करते हो. डोंट यू थिंक कि जी बॉटल रखिए, बच्चा लेके पी ले. और बहुत सारे बीइंग एन ENT सर्जन, सो मेनी इंसिडेंसेस बच्चों ने पी लिया, उनको पता नहीं था, बच्चा छोटा 3 साल 4 साल. आप लोग इतना सारा एथिकल बातें करते हो, तो ये चीज तो बाहर आप कोई भी बॉटल उठा लो, यू कैन नॉट ओपन इट अप. द लिड हैज टू बी प्रेस्ड अपॉन, देन रोटेटेड सो दैट इट कैन बी ओपनड अप. व्हाई डोंट यू पीपल टेक केयर ऑफ दैट?
Well noted as for the syrup is concerned, but patient safety may again there are a lot of pharmaceutical companies including Pharmevo that has introduced perforated strips for tablets, so that helps in identification of a medicine. क्योंकि हमारे पास especially
मैं उसकी बात नहीं कर रहा, मैं तो आपके सिरप्स की बात कर रहा हूँ ना जी, कि उसके अंदर परफोरेटेड क्या होता है आपका? कुछ नहीं.
कुछ सिरप्स ऐसे हैं जिनके कैप्स आर नॉन child friendly, जो कि प्रेस करके होते हैं, but majority of the bottles I would agree they are easy to open and that can be easily taken by kids. Luckily I was also a part of a project which I initiated that was for a drug and poison information center, and the majority of the calls which I had received at that time was regarding my child drank a whole bottle of hydraline which was there lying. So yeah,
बारकोड नहीं लगाते हो. बारकोड अगर लगा हो तो जो फेक मेडिसिन है वो काफी हद तक जो है वो नहीं लोगों को पता है. बारकोड लगाए थे कि जस्ट अपना उसे सेल फोन से चेक कर सकते हैं. आप लोग बारकोड नहीं लगाते.
Barcode is now being implemented by a regulation by DRAP, and it is now becoming.
अभी तो लगेगा. अब उन्होंने आपको
yes, but the still is there. They have started implementing international standards.
जो मेरे ख्याल में बहुत पहले आप लोगों को करना चाहिए पेशेंट सेफ्टी के लिए ना. हमें पता है कि फेक मेडिसिन इज अ बिग बिजनेस इन पाकिस्तान.
There are companies.
महंगी दवाई है, ज़ाहिर सस्ती दवाई कोई नहीं करता. महंगी दवाई का मतलब ये they are life saving medicines and they are fake. Patient dies, but that is the responsibility of the pharmaceutical company manufacturing that. They should ensure that the fake medicines are not there. The only way they can do
totally
it
agree.
is by putting a barcode. But unfortunately, we have not seen that.
Lekin, Dr. Saab, we also need to understand that unless and until the regulation enforcement is not there, as by culture, not only one pharmaceutical, but I would say even as professionals, we don't follow what we need to. So of course, जैसे जैसे regulations strong हो रहे हैं, जैसे जैसे requirements आ रही हैं, international भी और local भी, pharmaceutical companies are going towards this direction. The steer is there. It's going to take a little while.
मैं सिर्फ ये कहूँगा देर आए दुरुस्त है.
Alhamdulillah.
और दूसरा कहूँगा
मैं वही कह रही हूँ डॉक्टर साहब कि we are making a little ripples in the water and it's going to.
75 years हो चुके हैं, 78 years हो चुके हैं पाकिस्तान को. माशाल्लाह फार्मास्यूटिकल इंडस्ट्री के पास सबसे ज्यादा जो फ्लरिशिंग इंडस्ट्री है ना, आप जितना भी कह लें कि प्रॉफिट कम है, इस फार्मास्यूटिकल इंडस्ट्री. वी आर नो डाउट अबाउट दैट. लेकिन वही वाली बात है कि बहुत देर की मेहरबा आते आते तो ये चीजें जो है दे शुड हैव बीन देयर. क्योंकि अगर आप साउथ ईस्ट एशिया में दूसरे मुल्कों से कंपेयर करें तो वी आर फार बिहाइंड.
We are even in terms of regulations. Yes.
So in the end, I'll thank all the panelists for this very, and I hope जो लोग मौजूद थे they would have got some information.
Thank you so much.
They should have been learning, and a very important topic which was patient safety. That is at the core of heart of each one of us. I won't say that the pharmaceutical, hospital, doctors, nurses, each one of us cared about that. But one thing that we all agreed upon, that we are losing the touch with our patients. The empathy is not that what it should have been. What it is, what is the reason? And very correctly said कि मैं Zuhair साहब से request करूँ कि next time when you are having this program, then you can have a program dedicated to this, why we are not having that feelings and empathy for our patients that we used to have before. That will be very important for our new young doctors who are coming up. And what should be done? Should anything that we need to do at our curriculum level to add that, at our training levels in the hospitals, and the mentorship that was there initially now had been lost. And I don't blame anyone, but I think mushrooming of medical colleges is probably one of the reasons which I think has, because so many are there, the faculty is not enough to be meant to doing the mentorship. So in the end, I'm thankful to the organizers for organizing this program, and I'm thankful to all of you. और खास पे वो जो जैसे आप out of city आए, तकलीफ दी आए, and on behalf of the organizers, I thank you all. Thank you very much.
Thank you, sir. You moderated the session.
I don't know how I moderated, but
very grateful. It was absolutely wonderful. You did a great job, sir.
Thank you.
Thank you, sir.
Mr. Zuhair Nasir, CEO, Badar Expo Solutions, and Dr. Abid Abbas Sheikh, Organizing Secretary, Healthcare Expo, for giving away the shields to our esteemed panelists. Professor Aftab Mohsin, President PSIM. Dr. Naveed Ahmed, Pediatric Surgeon, PNS Shifa. Dr. Umaima Muzammil, General Manager, Farm Evo. Mr. Samad Salim, CEO, DigiTrends. Dr. Nashwa Zakaria, South City Hospital. Thank you all for taking out time and joining us today. Professor Tariq Rafi,